Um, Good afternoon, everyone.
Good
Thank you for joining.
afternoon, Ajin.
Yeah, thank you for joining this webinar. We're hoping to have a really interesting discussion, but I think maybe we give it a few minutes to have more people join because we've had so far about 200 people register. So let's just give it a few more minutes. Hopefully, we'll have a few people join and then we can kick it off officially.
Okay, that's fine.
That works. Thank you.
Um, Good afternoon, everyone. Good morning, good evening, depending on where you're joining from. I hope you guys can hear me clearly. Please let me know if you can hear me and see me okay.
Yes, we can.
Okay, fantastic. So once again, thank you for joining. Welcome, everyone. My name is Ajia Kiring, and I work for the TBPPM Learning Network, the Nigeria chapter. So what do we do at the TBPPM Learning Network? We basically try to facilitate learning around PPM within TB, especially from the Nigerian context. The idea is what is happening within the PPM space? What are we learning, as implementers, as people who are stakeholders within the PPM space? And how are we ensuring that that learning is being disseminated properly, that we're sharing information, that we're facilitating the whole process of learning so that we don't get so bogged down by implementation or get so bogged down by the problems around us, but we're actually stopping to prioritize how we're learning from what it is that we're doing and how we're using that learning to promote the goals of ending TB, especially through PPM. Um, One of the activities that we work on as regularly as we can manage is to conduct webinars on topical issues, on things that are affecting the PPM space. And then it's an opportunity for a robust discussion among stakeholders and people who are working in this space, both from within the Nigerian context and outside Nigeria, so that, it's basically an opportunity to just basically discuss. And it's on that basis that we're having this very, very relevant conversation today. As we all know, there has been a shift as far as funding is concerned. Priorities are changing, things are evolving, and as a program, we are figuring out how to respond to that. How is that affecting the work that we're doing? How has that affected the status quo? And what are we going to do going forward? What are the opportunities that exist? What are people doing outside of TB? What have people done in the past before? What has the TB program done in the past? And how is that going to change going forward? So not only are we going to be speaking to people within the PPM space, we're also going to be speaking to people outside the PPM space here, getting insights of what other programs and what other approaches have been employed, especially around mobilizing resources domestically, and how exactly can this be applied to our current situation. So overall, that is basically what we're going to be talking about. um, I will pass it on to Stella Maku of the National TV Program, the PPM unit, to take it from here. Over to you, Stella.
Thank you very much, Aji. I've just called our acting national coordinator, but right now he's about to join. So before he joins, to look at the logistics, we have 5 seasoned speakers, well-grounded, and presentations on domestic resource mobilization, a pathway to long-term sustainability for PPM activities. So we're going to be hearing from them, and we have a lot to learn because Nigeria is moving towards getting our resources from within and managing it for TB activities. So it will be good we listen to all our speakers so that we'll pick one or two things, one or two things that can help us move forward. So now the speakers will be given 10 minutes each. 10 minutes each. And this 10 minutes, let it be 10 minutes so that we'll be able to, we will not be able to start scouting for time or hurrying up at the close of the day. So now at the end of the presentations, we're going to have discussion time where we can, all our concerns, our questions, so we can use the chat box to type our questions, or we can, use a raise hand icon so that we'll be given the permission to do that. So all our contributions, so we will get them, entertained and solved. So now, before we go into the webinar proper, I would like to, it's like the national coordinator is not yet here. Maybe I can reach out again to him, but he told me he's joining. So, or maybe Dr. Obioma, can you stand in for him? Is it possible?
I think he will join. Whenever he joins, he can
Okay, whenever he joins. Okay,
Yes.
that's
So can I
fine then.
suggest?
Huh?
Sorry, I just wanted to suggest that can we begin with the presentations, and then when he joins, then we take a break, and then he now does his goodwill message. Will that work?
Okay, we can start with the presentations then. At the end of the day, you make the okay.
Yes.
No
So
problem. It's okay.
whenever he joins, we can pause, and then he can speak then. I think
Okay.
that will work if that works for all of us. I also wanted to just
Hello, sir.
remind us all before Dr. Obiama starts the first presentation that
Okay, you're here. Oh, I'm not seeing you. Okay, sir. Thank you, sir. Okay, he's already here. So I would like to call on the acting national coordinator. National Tuberculosis, Leprosy, and Bruley Ulcer Control Program, Dr. Clement Adesiwin, who will give us his welcome address. Dr. Clement, sir, you have the floor. Thank you. Hello, sir. Sir?
Hello. Hello.
Thank you. Yeah.
Good afternoon. Good afternoon. Can you hear me, please?
Good afternoon,
Yeah,
sir.
good afternoon,
Yes, I
sir.
can hear you loud and clear.
I joined this call almost before any other person. I'm surprised how you could not identify that I joined so early before. Maybe I don't know. Maybe anybody joined earlier than me. I'm not sure. Okay. Just to thank the organizer of this platform. Like I heard, it's a learning platform, and that's very great. We can pull ourselves out of our busy schedules and share experiences and make our work better. I think that's very important. Not just doing the same thing over and over, and not looking at other innovations from maybe even from our colleagues or even outside our colleagues. It doesn't have to be limited to Ministry of Health. There are other ministries, other very key stakeholders that can bring their experiences to bear on what they are doing that may really rub on our work and make our work better. So it shouldn't be limited to Ministry of Health. We know ourselves so well. And so if it's the same faces here again and again you are seeing, it's like I don't know, it may not be that interesting. So we also need to look outside other experts that can better improve our work. I'm really happy that we are taking one of the most difficult priorities of the program. A very, very important challenge that we have is a priority, but maybe it's at times it's difficult to even discuss. We list it as our problems anytime somebody asks, but I'm not sure we have really sat down so well and say, let's discuss it. Of course, we've had some platforms and some coming together and looking at how we can raise better improve domestic funding. I know such has happened, but this is one platform that is going to further discuss that and be able to profile maybe other ways by which we can improve domestic funding. It's I won't say it may not be that bad the way some of us may be looking at it. It may not be that bad. Of course, when you look at data, it may look so bad, but we may be underreporting what we are. What we have in terms of domestic funding may be underreported. I know what we say is 8%, and now it's down to 5%, but that may be the other reportage. I know some of our subnationals that are actually contributing, but are not well reported, not well captured. Not only in terms of putting money on the table, there are other ways of funding that may not be money. It may be infrastructural supports. It may be, and those things may not be well calculated, may not be well, what they call it, may not be well enumerated. And so we continue to look at that bad indicator, bad figure that domestically we are not doing well. But I think one of the things we also need to look at is how do we come out with a template that can actually be very encompassing, that can not only looking at maybe fund or money that are put down on the table. Are there other things that come from our government, from private organizations, from well-to-do people who have been supporting the program? How do we ensure that we can capture all of this and be able to speak well about what we are getting domestically, and not when we find ourselves in international fora and all we said is less than 10%, whereas it's far above that. If we can well capture what we are getting internally for TB support. So I won't want to be quoting figures because I know we have experts that we have identified that will be looking at those indicators for us. But I just want to put it on the table that I feel one of the recommendations that should be coming out is how do we get a very good template to capture what we get in terms of domestic funding, not only from national, but across our submission. So I want to leave it there and wish us well in this meeting. Thank you, and over.
Thank you very much, sir, for that wonderful opening remark. So we have heard it. We cannot do with domestic funding because we need to augment what we are getting from the funders. Then there are other ways we can fund, and that is not necessarily money. So there are other ways that TB activities can be supported. But most importantly, there is need for us to come up with a template that will be able to capture what we get from domestic funding. So now I would permit me to introduce our first speaker for today, and is no other person than Dr. Obioma Chijioke Akaniro. Dr. Chijioke Akaniro is the M&E Manager, National Tuberculosis, Leprosy and Bully Ulcer Control Program. She will take us through sustainable health financing for TB in Nigeria. So, Dr. Akaniro, please, you have the floor. Thank you. And you have 10 minutes. Thank you.
Thank you so much, Stella. Good afternoon, everyone. Thank you for this opportunity. My name is Obioma Chijioke Akaniro, and I'm presenting on sustainable health financing for TB in Nigeria. I'll present based on this outline, but to start, I just want to define that health financing is such a package. It includes the process of how money is raised and spent for healthcare services. And going beyond that, there are other processes of ensuring access and financial protection for individuals and communities. Of course, health financing individually in countries is not just about what the country does, but it's pointing towards a global strategy and also towards helping out in global targets and achievements. It comes as a trio with global health, globalization, and health security, because within health financing, as you express and ensure equitable access to quality healthcare services, you're also helping to address shared health challenges among the global corridors, especially for TB, which is an airborne disease, and of course, how much we're able to strategize and control it within the country. Nigeria, which is also a high-burden country, will do a lot in reducing the transmission over the world. So based on this, both health financing, global health, and health security play a key role, and Nigeria must always be at the forefront to ensure that health financing is given optimum attention. Healthcare financing in Nigeria, there are different ways. We have the government, which includes the national, state, and LGAs. We have the out-of-pocket expenditures. We have the health insurance schemes, which can be the social, community-based, or private health scheme, private schemes, and we have the donor funding. But within the Nigerian landscape, we have most of the financing coming out of pocket, which is almost 70%, then followed by the government spending. So with the dynamics of having more of out-of-pocket expenditure shows that there would also be reduction in health access or health services access within the country. And based on it, that is what brings us to the challenges for the health sector as health financing is concerned. So first of all, in terms of allocation, Nigeria have struggled to do up to 5% allocation. Of course, we know that this is just monetary. We're looking at the monetary allocation, and tying it with the Abuja declaration that says that we should have up to 15%. Nigeria has not been able to get to that 15%. And it's actually, when you look at it, that the declaration was made in Abuja, we should be also thinking of us pushing forward to be on the forefront of making up this 15%. But with this low allocation and probably low expenditure that we have within the country, we would also see trickle down in every other thing that has to do with access to healthcare, universal health coverage. So with that, you will see the reason why we have low government spending and also increased out-of-pocket expenditure. There are key things that the government is doing to help to improve health financing, including the National Health Financing Policy, the Basic Healthcare Provision Fund, which is giving 1% of the Consolidated Revenue Fund, strengthening health system. But with all this, you would see that even coming down to the TB financing, we are mirroring exactly what is happening at the national in terms of the total health system. We still have our highest coming up in terms of donor than the domestic resources, and our out-of-pocket expenditure in TB is also high, as over 70% of our TB patients and household are suffering catastrophic costs. So averagely in a year, about 30% of the TB budget is funded. And within that 30%, we have about 85% of it coming from the international or donor funding. And sometimes within the range of 5 to 10% will come from government. The skewing of this international funding, it's actually not so good for our system, because sometimes those funding come with their own priorities, and sometimes the implementation strategies don't fit into the government established system, and by that it becomes less sustainable. And also, looking at the impacts, a lot of them don't make so much impact because they are kind of swinging out of the system. And the impact sometimes, because of the number of years it takes to measure the impact, and having this funding that might just be flowing up and down in terms of regularity, you would also see that the years required for us to muzzle up to have that strategic impact that we need as a country might not really show up, even though that we are seeing some upturns in terms of coverage and upturns in terms of outcomes. So in TB program, mirroring down, we see percentage domestic funding annually is actually decreasing. And this is decreasing in times where every year we have increase in burden, we have increase in target. We also have expected increase in scope for us to ensure universal health coverage. And even though the international funding, which we say seems to make up, we have plateauing of the international funding. So keeping the Nigerian TB program in a space where we need a lot more fund. And added to the point that insurance coverage is not yet elaborating the TB services, it exposes our patients to out-of-pocket expenditure. So Sustainability for TB program, to help us to build to help us with sustainable financing, and for us to build a strong response for the program, we definitely will need to shift from international funding to domestic funding. In fact, to just flip the coin to have more of the domestic funding than international funding. And this would require us to deliberately integrate TB into key aspects of the national health financing system, improving our budgeting and planning processes, keying into some aspect, the midterm expenditure framework, any other thing that the government does that will help us see TB a lot more visible within the space, promote public-private partnership by engaging the PPM for them, the organized private sector, to help in terms of fund mobilization, and also engaging the private sector, especially the non-governmental organization, in things like contracting, social contracting from the government. So all this would help us to build a sustainable TB program. But additionally, for us to see exactly where we are in terms of sustainability in programming, financial sustainability in TB programming, we will need to address ourselves to know exactly where we are. What's our baseline? What have we done well? Can we have a benchmark that we can renew every 2 years, 3 years to see how well we are doing? Just like the national coordinator said, we should have one document that puts together a whole lot of things, not just the funding, but seeing through end to end to see this is where we are as TB program. And this is what we can benchmark ourselves and build up with. There's a tool called Financial Sustainability Index, which Nigeria was able to implement, TB program was able to implement, thanks to the USAID and the Bill and Melinda Gates Foundation for this. We were able to apply this tool across the national TB program. In putting up this tool, there are 4 different components that we looked into, and it brought together different sectors, both the health sector and the non-health sector, they were all sitting together to look across it, whether from budget, from finance, every aspect, to look at where we are as a TB program, and also know the places where we have gap within ourselves as a program or gap within the financial sector as relates to the TB program. So the components of this financial sustainability index looked at our efficiency in planning and budgeting cycle, our efficient use of resources, our sustainable financing, and financial protection. And the Nigerian TB program has been costed along the benchmarks of these 4 components. There were best practices from what was identified from what we do as a TB program, and that cuts across 2 major areas. The fact that we have intervention level costing of the NSP for the program, and the fact that we have a TB financial sustainability plan, which has within it domestic resource mobilization strategies. So these together were best practices that we're seeing from the program, and also something that we should maintain as a program. It also showed that within 2024, we had a more increase, like there was increase in the expenditure of TB. The government actually gave more to TB in 2024, which changed the landscape from what we had seen.
2 more minutes, 2 more minutes.
The result of this financial sustainability index and the gaps we observed as a program, and which this is where we need to put a lot more effort, is the fact that our planning and budgeting is not elaborate. We need to incorporate and do more in terms of planning. Then the tracking of our budgets, like tracking and reporting our budget expenditure, is also another place, because in this tracking, we'll know what we have done well, what we've not done well, and what we should focus on. Then our available funding and funding resources were not aligned to our strategic plan, and this is what we need to do in terms of our next strategic plan. So our recommendations was prioritizing our integration of TB services into our health insurance scheme. This discussion is ongoing to ensure that TB benefits from the health insurance, and for the government to include our NSP resource needs into the MTEF or any multi-year financial plan that is held by the government, and government to enforce policies and procedures to hold the subnational level accountable. So as TB program, what we have also done in partnership with different organizations, with Stop TB Partnership, we've done the private sector matching fund, where the minister brought up a $50 million matching fund with private sector. We also had the First Lady, who has released over the 2 years now about $1.5 million. We have been able to integrate TB into the Basic Healthcare Provision Fund, and we are working on the tracking mechanism of the Basic Health Provision Fund and our ongoing integration into the National Health Insurance. So in the midst of all this, especially with the new political landscape and the public health landscape of the USG Stop Fund, I also want to say that our president have also released about 700 billion naira for STB and malaria for mitigation of the gaps from this. So finally, our next steps to financial sustainability is to just identify these unmet the domestic financing needs. And presently, that is what is going on between this month and the next 1.5 years. This will be going on. A multi-sectoral and coordinated planning, better tracking, patient access to financial protection, more efficient and effective use of resources, then to implement our TB investment case, which has become an advocacy tool for us. So in concluding, we would not stop on advocating, because we know the Human Capital Index is important. It's a metric by the World Bank to assess how countries have been able to how much each country loses in potential economic productivity due to underinvestment in health. And if you look at the TB, the demographics of TB, and also looking at the population, you will see that TB is affecting our youth, and based on that, is one of the diseases that is fighting our economic productivity. Therefore, is one of the diseases that this Human Capital Index is also viewing. So by that, our healthcare financing will help to contribute to our socio-economic development. So the national program would ensure that the return on investment is used for advocacy this year, next year, and to ensure that we build a better sustainability plan for the Nigeria TB program. Thank you.
Thank you very much, Dr. Obioma. So we are happy with your presentation, and we are glad you have let us see where we are coming from. So there is need for us to give optimum attention to health financing. And most health financing we have seen comes from out of pocket expenditure of patients. Then of course, we know that government spending is getting lower, while the catastrophic cost coming from patients is getting higher. So donor funds, we know, comes with priorities. So donor funding is actually not sustainable for us. The percentage domestic funding is decreasing, and international funding they are not sustainable. So TB service should be integrated into the health insurance system. I think Nigeria is working towards that. And of course, the Honorable Minister of Health and Social Welfare had this matching funding from the private sector. And of course, the donation of TB lab machines by the First Lady. So thank you so much for making us see all of this. So I would also want to introduce the next speaker, and that is Mr. Mayowa Joel. Mr. Mayowa is the Executive Secretary of Stop TB Partnership Nigeria. He will share with us some Stop TB Nigerian domestic resource mobilization efforts, and he will be given 10 minutes to share all these experiences with us. Mr. Mayowa, please, you have the floor. Thank you.
Thank you, Dr. Stella. Good afternoon, everyone. I want to highly commend and appreciate TBPPM Learning Network, as well as the National TB Control Program for organizing this webinar. This is very timely, considering, like Dr. Obioma put it, the change in the TB funding landscape. Sorry, I'm not going to, I don't have a fancy slide like Dr. Obioma. And actually, most of the things I will be presenting, she has presented it, because we work together, we share the same information. So I'm just going to go a little bit detail into some of the issues she highlighted. So I'm supposed to talk about the ongoing DRM efforts, that domestic resource mobilization efforts, and what has been achieved so far and future prospects. Like I said, she mentioned this briefly in our presentation, but let me deep dive a little bit. Let me start with the big one. The government of Nigeria committed about 700 billion naira to HIV, TB, and malaria. This is the one of the remarkable reaction of the federal government to the stop work order by the US government, which, as we all know, affected many of us, including the TB program. I think for the first time, we need to commend the government of Nigeria for this prompt action. We've always talked about very inadequate financing for TB, but for the first time, the government of Nigeria has stepped up and decided to take the bull by the horn by giving such large amount of money. And I can say that a lot went into this achievement from the leadership of the Federal Ministry of Health and Social Welfare, the person of Professor Mohammed Ali Pate, who actually stepped up and showed effective leadership in the course of the or in this situation. We also appreciate the support from the National Assembly and all the other stakeholders who actually joined in advocating and providing information that led to the allocation of this money by the federal government. So, and that is a big achievement from the public sector, and it's very important for us to recognize it, because usually we always say the government do not give enough. Yes, but now they've given something substantial, and but not that it is enough to resolve all the issues, TB issues in Nigeria, but at least it's something. But let me correct, or let me clarify that the 700 billion is not only for TB. Again, it's for HIV, AIDS, TB, and malaria. At least to cushion the effect of the stop work order. So that is one big achievement. Another big achievement is being from the private sector. First, we have like Dr. Obioma mentioned, the 50 million matching fund. Now, from the public sector and the private sector. As of July last year, when we had the private sector event, the Honorable Minister promised $25 million from the public sector. Obviously now, the public sector has given more than $25 million. So now we are now, should I say, following up with the private sector to fulfill their own part of the agreement, even much more than that. The private sector constituency on TB is being led by Chief Ike Imogede of Access Bank, and we are working with him and all other high-level private sector stakeholders to ensure that they're able to fulfill this commitment either in kind or in cash. We can, of course, let you know that there are many private sector organizations that have been doing, a lot of or contributing significantly to TB to support in one way or the other. We are aware of 20 TB lamps that are donated by the BUA Foundation. Ashafa also donated some diagnostic machines. We very much aware of Chevron Agbami that has been contributing significantly to infrastructural development in the TB sector. With support of Gates Foundation, Stop TB Partnership Nigeria, in collaboration with the National TB Program, we're following up with the private sector to fulfill their own part of the agreement of $25 million. Of course, we're reporting back on that. And let me also mention that we are also engaging with philanthropists. Her Excellency, the First Lady of Nigeria, has been at the forefront of that. And she's been, so far, through the Renewed Hope Initiative, has donated over 2 billion naira for TB. This is remarkable. We've never seen anything like this before in Nigeria, and so this is part of the achievements we have recorded so far. And something she's also doing behind the scene, which I need to also bring to our attention, is that she's calling on her private sector and individuals to donate. And so far, they've also donated significantly to TB. And so far, we're talking about to the tune of about 200 million that our friends have also donated. So this is something that's also worth mentioning. And let me also mention that recently, Stop TB Partnership Nigeria, we are on advocacy visit to the states. Like the acting national coordinator, Dr. Clement, mentioned, we discovered that states, hello, can you hear me?
Yes, we can hear you.
Very
We can
well,
no
yeah.
longer see you, but we can hear you.
I have to go on without the video. Sorry for the power outage there.
No
So
problem. We can hear you loud and clear.
we discovered that in the States that there are many support for TB that are not recorded at all. And it's a Stop TB Partnership Nigeria. This is one important aspect of the assignment we would like to take forward in collaboration with the National TB and Leprosy Control Program. The support from the subnational are in a way contributory to what is happening to the TB financing at the these are not being captured in any way, any form or shape. And we need to put in place structures to be able to do this. Another prospect for the future is the private sector constituency on TB. We'll be working with major private sectors or through other innovative financing mechanisms to see how to increase the funding of TB financing for TB Nigeria. Lastly, there's still room also for improvement from the government of Nigeria. We know we are not totally out of the woods yet when it comes to being able to adequately fund TB program. So we need to still continue to advocate to the government, both at the federal and state level, to ensure that it continues to provide or sustain the amount of funding for TB. Another important prospect is our engagement with the Nigerian Governors Forum. Nigeria, there's significant amount of resources at the state level that we can tap into, and by working with the executive governors in the states through their wives as state TB champions, we believe we can also increase the resources that is coming from the state. So I think briefly, these are the achievements so far.
Hello, Mr. Maiwa.
Yes, can you hear me?
Yes, we can hear you now.
Okay, so I'm concluding by saying that there are a lot of key actors who are now who have been supporting the efforts to increase resource mobilization in Nigeria. The Gates Foundation, the Global Fund is also supporting Stop TB Partnership Nigeria to increase or intensify domestic resource mobilization through some grants through IHVN. That also we recognize, and we hope that by bringing all this together, we'll be able to significantly increase
Hello, Mr. Maiwa, we have lost you. Hello? Hello? Hello, Mr. Maiwa.
So I think we can move on.
Hello.
Yes,
Hello?
we're losing you. We're losing you.
Okay, but can you hear me now?
Yes, we can hear you now.
Yes, go ahead.
Okay.
But you should be rounding up now because your time is up. Thank you.
I thought I actually concluded. I didn't know you didn't hear me. So I think we have prospects in the public sector at the federal and state level, like I said, we need to continue to advocate to the federal government so that they can sustain the level of resources they have injected into TB program. We also have prospects through our engagement with the Nigerian Governors Forum, so that we can also enhance resources from the state and even through the local government, especially now that resources are going directly to the local government. And lastly, we have a lot of prospects through the private sector, and we are leveraging on the private sector constituency for TB that was established in July last year. And we will be working with the Gates Foundation, we'll be working with IHBN with support of the Global Fund to be able to bring together key private sectors so that TB financing can be an integral part of their CSR or through other innovative financing mechanism. Thank you, over.
Yeah, thank you very much, Dr. Mr. Mayowa. Thank you for sharing with us. Hello, okay. Yeah, thank you for sharing with us your thoughts. So now we have, there are prospects, still more prospects in public sector. And we have this private sector constituency on TB. We can increase our TB funding through that aspect. The federal government can still do more. The engagement with government, with Nigerian Governors Forum can still help us harvest funding for TB program. Then the federal government, of course, need to be commended for their prompt action by stepping up TB funding. And of course, support from the National Assembly by way of advocacy. Then, of course, a lot of follow-ups on private sector funding is ongoing. Then some private sectors like BOA, like Agbami Partners, they are donating their parts, and we also need to engage with philanthropists. Of course, this First Lady is doing a great job in that aspect. So thank you, Mr. Mayowa, for this presentation. So I think I'll hand over to Aji to continue with the other presenters. Thank you. Aji. Hello, Aji.
Oh, thank you. I was trying to unmute. So thank you so much for the presenter so far. It has been super interesting and very, very informative. So now we're going to go over to Dr. Sheshi from KNCV to share the experience they've been having. Dr. Sheshi, do you want me to present or would you present? Should I present for you and you?
Let me present. Thank you.
Okay. All right. So yeah, so Dr. Sheshi will be sharing the experience from KNCV's and TB Loan 1 and 2 and what has been happening since the freeze. So yeah, so Dr. Sheshi, over to you.
All right, thank you, Aji, and good afternoon, everyone. I'll be presenting on behalf of KNCV Nigeria the impact of the USAID freeze on PPM activities and our plans at KNCV for sustainable financing. I'll be speaking specifically to our TB Loan 1 and 2 projects. This is the outline I would use. I'll just go right into the presentation. So just some background information about KNCV Nigeria. We've been supporting the government of Nigeria since 2004, where we started implementing successive cycles of USAID funded projects, the TBCTA, TB Care 1, TB Cap, TB Care 1, Challenge TB projects. And somewhere in 2016, we started our transition process to become a local entity. We had technical and managerial capacity transfer, which was concluded in 2020, and we kicked off fully as a local indigenous national entity. We started off with our flagship project, the TB Loan 1 and 2 project, and since then we have increased in our project portfolio. It's listed there for us to see.
Our footprints across Nigeria, we have footprints across all 36 states of Nigeria and the FCT, and very specifically to the project I'll be speaking about this afternoon, the TB Loan 1 and 2 project. We can see in green there, across 14 states in the country, running from the northwestern part of the country through the north central, northeast, the south, and the southeast parts of the country. Before I go into domestic resource mobilization, I'll just talk a little bit of our private sector activities at KNCV Nigeria. So at KNCV Nigeria, all projects that we implement has a private sector component. We have a directorate for private sector, but we have 3 major projects which we have implemented that have a specific focus on the private sector. We have the TB Loan 1 and 2 project, which I'll be talking a little bit more about later. The Global Fund Community and PPM grants, these we are sub-recipients to IHVN, and we're implementing these across 7 states. And the Tuberculosis Implementation Framework Agreement grant, TIFA, in which we implemented social franchising for TB contact investigation in Kano State. This was specifically focused on the private sector, and it's a project that has been completed. Now, some of our strategies in implementing private sector activities. For one, we engage all private care providers. Wherever patients go to, we ensure that we engage that cadre of facilities. So our engagement ranges from the hospitals, the clinics, the patent medicine vendors, community pharmacies, standalone labs, other traditional institutions where patients go to. We ensure that we also provide TB services in those facilities. We also run a hub and spoke model to ensure that we have effective linkages and we're able to support all engaged facilities. We have a mixed implementation model. So in some states that we implement the TB Loan 1 and 2, we implement directly our private sector activities. And in some of these states, we use sub-recipients. We contract out this implementation, and sub-recipients implement for us. We also implement a negotiated business model. Of course, we know the language the private providers speak, and we ensure that most of the work that they do is incentivized, and we make sure these incentives are performance-based so that we'll also get value for money. We also try to ensure that we provide recognitions and awards for outstanding performances as a way of motivating our providers. Flexibility is at the core of what we do, because the private sector is an ever-changing space, and of course, we try to be flexible to meet the demands of the work. Just a little bit of schematic to show us in numbers what we have done on the TB Loan 1 and 2 project right from when we started. This is a quarterly data, and we can see it has been on an upward trend, except for the early parts and the last parts of 2022. And then, of course, in 2025, where we had the nosedive. We'll talk about this a little bit later. To also show perspective in terms of our private sector work as a subset of the total work we do, it's also been an increasing trend. We started out in 2020 for the TB Loan 1 and 2 project, and we started as low as 11% private sector contribution to TB case finding for that year. We have grown. Last year, 2024, we had 36% private sector contribution on the TB Loan 1 and 2 project. That's over 37,000 TB patients diagnosed and placed on treatment. A whole lot of numbers, I can assure you. Now, besides the TB Loan 1 and 2 projects, I'd also mentioned that we also implement the community and PPM grants, which is a global fund grant, and it's also been on an upward trajectory. You can see from where we started last year to this quarter from the private sector, we're able to get about 15,000 TB cases. Now, KNCV Nigeria has also made some efforts in domestic resource mobilization in the lifespan of the project. Some background information, Dr. Obioma had talked about some of this when she made her presentation, but just to remind us that Nigeria is 6th in terms of TB burden across the world. And in 2023, we diagnosed over 367,000 TB cases. Catastrophic cost for TB is really high. Dr. Obioma had mentioned this. As of 2023, it was about 71%. Funding available for TB, it's about 137 million, and most of it is from international funding. The government of Nigeria is also doing its own part in terms of providing the human resources, but we all know the challenges with human resources in Nigeria. It's inadequate, they are understaffed, and then there's the staff attrition challenges. The JAPA syndrome, quite a lot of staff are leaving the country to seek greener pastures, and that significantly impacts on the TB case finding strides, especially in the private sectors. International donors provides about 35% of our estimated financial needs, and there's a funding gap of about 60%, most of which comes out of people's pockets. State TB programs, as the acting national coordinator had said, also do their own part. In most of the states, there is at least some allocation for TB programming. Release has been the challenge, but some states have started waking up. And of course, beyond monetary value of some other states also bring some other things to the table. Some get diagnostics, some motorcycles, and other things to improve TB control across the states. Now, in 2021, KNCV Nigeria, we engaged coordinating consultants in our 14 TB Loan 1 and 2 states, primarily to drive domestic resource mobilization efforts. Now, the goal was to drive states' domestic resource mobilization activities to increase funding and integrate TB care in states' health insurance scheme, minimum health benefits package. The objectives are listed there. These consultants went to work, and we would see what they were able to achieve in a few slides from now. Now, roadmaps and action points from these assessments that these coordinating consultants carried out inform for fund release and request to approving authorities. Just to show a little bit of what we were able to achieve in some of the states where we were, I would say, relatively successful. We were able to get government's commitment, and there was a demonstrable increase in the funding allocation for TB. We can see across 5 states that we support. Benue, for instance, before we started our domestic resource mobilization drive, was giving just about 5 million per year. But the very next year after we started, that increased to about 55 million. And we can see the drive across some of the other states. This was in 2022. In subsequent years, it has also increased in some states. Katsina State, for instance, is giving close to 200 million on a yearly basis presently to control TB in the state. Now, going to specifics, the impact of the USAID freeze on the TB Loan 1 and 2 PPM activities. Now, as at the time when the stop work order came, that's in January 2025, the TB Loan 1 and 2 project had engaged over 3,700 private health establishments for TB control. These included over 700 hospitals and clinics, both primary and secondary healthcare facilities where we provided TB care. Also, over 2,700 patent medicine vendors, chemists, which is really one of the providers that knows a lot of TB cases, especially in the northwestern parts of the countries. Also, the community pharmacies, we had engaged about 135 and 117 private medical laboratories. What were some of the activities that we do in these facilities? Of course, we supported trainings, supportive supervisions. We placed screeners in some of these facilities. We supported sample transportation, contact investigation, performance-based incentives for TB case finding and also for case retention. And then we also supported data harmonization and review meetings. Now, we stopped work on January 23rd, 2025. And thankfully, we got a resume work order on 12th of March 2025. However, we had a 7-week period where all field activities had stopped. So for all of these facilities which were supporting for activities, everything came to a grinding halt. The effect was really severe across all thematic areas, and PPM was also significantly affected. There was a drastic drop in TB case finding from the private sector in the TB Loan 1 and 2 states. And beyond the drop in numbers, we had developed trust, because it's a relationship we develop with these private healthcare providers. We had developed trust, and that trust was severely disrupted. Now, going back to look at this chart, I had shown this before. We can see that we had increased in our TB case finding. This is specifically from the private sector in the TB Loan 1 and 2 projects, 14 states. And we had reached our all-time high in July to September of 2024, where we were able to diagnose and put on treatment 11,800 TB cases across these 14 states. In between October and December, there was a slight decline, primarily due to the drug shortages which we experienced at that time. But then we can see that in Q1, we nosedived, and that's coincides with when the stop work order came. From our high of about 11,000 TB cases in a quarter, we dropped down to last quarter to just about 3,500 TB cases. I'm very sure Dr. Obioma will not like to see this, and I'm waiting to try and explain myself next week in the zonal review meeting to her. But then we can see we have dropped, and this has taken us about 3-4 years back. This just mirrors what we were doing in 2021, 2022, and it looks like it has eroded some of the gains. Looking a little bit more closely at what happened within this week, we even did a weekly analysis. So this chart is showing a weekly trend from October of 2024. We run our cycles from October to September. So starting from October of 2024, we can see on the average, we're diagnosing about 600 TB cases in a week and putting quite a number of them on treatment. But from week 18, which coincided with the stop work order, everything came to a halt. And for those 7 weeks, we did not diagnose or notify any case from these facilities. Thankfully, we came back and we tried to bounce back and go back to what we used to do very well. So, summarizing the effects of the stop work order, of course, primarily there was a reduction in funding for PPM activities, and then the health workforce for PPM activities was also reduced because we have linkage coordinators, screening officers, and other ad hoc staff which we utilize to carry out these activities. Those were reduced. There was a significant decrease in the TB case finding, as we have seen. We had service disruptions across our private sites, and then treatment interruptions for clients on care. And of course, that leads to increased morbidity and mortality for these TB patients. What are some of our plans on how we want to go on from here? For one, we would like to scale up our domestic resource mobilization efforts, and we'll build on the lessons we have learned, especially from our pilots. We saw that indeed, if we invest in domestic mobilization drive, we'll be able to get these resources to ensure that we continue with our services uninterrupted. We'll also continue to build the capacity of the state TB programs and the state health insurance scheme on strategic planning, budgeting, and facilitating fund release from the government. We would also work with the National TB Program and, of course, Stop TB Partnership, who we've been working together with, to also engage private corporate organizations for TB funding as part of their social corporate responsibilities. Mr. Mayowa had talked of some of the successes that has been achieved from these private organizations, and we will continue and also support that drive. Of course, we will also continue to support the National TB Program on all aspects of PPM implementation in Nigeria. Finally, in conclusion, I would just like to say that while Nigeria is making efforts to mobilize domestic and private resources to sustain its TB response, the projected decline in international funding underscores the need for a sustainable, diversified financing strategy. Continued collaboration between the government, private sector, and international partners is essential to ensure the availability of resources for TB prevention, diagnosis, and treatment. That will be all from me. Thank you from all of us at KNCB. Thank you.
Thank you so much, Dr. Seshi. Thank you for that very interesting and very emotionally, should I say, it really captured the reality of what this means to the country when we see the stark numbers and we look at, the gains basically eroding right in front of our eyes. And I think, as you mentioned, if nothing else, what it accentuates, what it emphasizes is the need for what we're talking about right now. We need more sustainable ways to finance what it is that is really, really important for us to do. Because, I mean, it cannot be overemphasized that we really, really do need these issues, that their needs, right? Within the TB space, we have needs. Within PPM, we have needs. Within health in general, we have needs. And even beyond that, we continue to have needs. But the way we have been funding it and financing it has never been sustainable. So this was basically a ticking time bomb. This was something that was bound to happen at one point or the other. And I think it's a stark reminder that even the resources we have right now, even Global Fund that seems secure right now, or any other source of funding that seems secure right now, can evaporate right before our eyes, and the impact of that will be catastrophic in the lives of the people of our country that we care about. So definitely something worth discussing. Thank you so much for that. So next we'll move to Dr. Ronke to share the experience of TB Loan 3 from the IHN perspective. Please go ahead, Dr. Ronke. Do you want me to present for you?
I think I'll just go ahead and present. Thank you, Aji.
All right, thank you.
Well, thank you very much for the opportunity to share these few reflections. I hope you can hear me and see me clearly.
Yes.
Okay.
Yes, we can.
Okay, great. On the impact of the stop work order on the TB Loan 3 project, as well as the opportunities for domestic financing. So this is my outline. Basically, as has been said by the other presenters, Nigeria relies heavily on external funding to drive the TB program. And the reality is that this funding continues to shrink as in the light of the recent developments And the key question we need to answer is how Nigeria can sustain the achievements and also meet the UN high-level mission targets without donor dependency. So specifically for the USAID TB Loan 3 project, the goal was to innovatively engage all stakeholders as well as mobilize domestic resources to sustain TB programs in the supported states and nationally as well. And one of the key stakeholders identified for this initiative was, of course, the private sector, where over 60% of Nigerians access healthcare services. Domestic financing, health financing, or resource mobilization itself is not a strange concept. It was one of the objectives of the TB Loan 3 project, and were to focus on increasing government funding in the states we're working in, TB in the health insurance, state health insurance benefit package, and also ensure the enrollment of TB patients on social health insurance. Looking at the intervention framework for the project, we see domestic resource mobilization as a key component, and also the engagement of the private sector for TB services, of course, with all the wraparound activities described by Dr. Sheshe in his presentation. So the easiest way to describe the impact is what we can see on the screen right now: a rapid decline in TB case finding and notification, about 70%. That happened instantly within the quarter of the stop work order. And this impact, of course, Dr. Shesh had mentioned earlier about the provider coverage. We had over 500 hospitals, over 1,000 informal providers on the project, ad hoc staff, etc. So I'd like to take this a notch higher so that we can appreciate the potential impacts of this if this were to happen nationally, if something similar were to happen nationally. IGN is the principal recipient for engaging private sector for TB services, and we can see the number of providers we're interacting with to date and increasing, over 21,000 providers now. And we have over 80% of those providers being in the informal private sector. So this is really critical as we move forward, looking at how we sustain the gains of TB private sector engagement in Nigeria. Looking at the numbers, over 26 million Nigerians screened in the last 5 years, over 300,000 placed on treatment in the private sector. The informal private sector still contributed the lion's share of these numbers. The gains we've had over the years need to be sustained. When IGN started as the principal recipient, scaling up TB engagement in the private sector in 2019, we're seeing as many as 12,000 TB cases notified, and now we're talking about 134,000 in 2024. These gains are at risk if we continue to see the decline in donor funding that we're seeing now. Also, looking at the cost effectiveness, there was a study, a cost-benefit analysis done by WHO that showed that there's more dollar per case saved compared to traditional models of TB service delivery. And we need to act now to sustain those gains. What are the risks of global funding cuts to Nigeria? The TB budget, as outlined in the global report of global TB report in 2023, was $393 million. Of that, we had only 137 million available. And as Dr. Obioma said earlier, 85% of that came from international donors. Just doing like some quick and dirty calculations and projections, we anticipate that by 2026, we may have as high as $276 million funding gap for the TB program. And what would be the consequences for the private sector? We project that we may lose We may not be able to detect up to 60,000 cases annually, reversing the gains we've made in the last 5 years. And as high as 25% of those providers, if not more, may fizzle out, leading to a rise in TB deaths in the country. I had mentioned the cost effectiveness of the PPM model earlier, just to highlight that in 2022, the National TB Program and WHO estimated that the PPM programs in Nigeria reduced TB treatment costs by 30 to 40%, while the cost-benefit analysis I mentioned earlier in 12 high-burden countries conducted by the World Health Organization showed a savings of about $150 to $300 in TB programming by reducing delays per patient, by reducing delays and improving efficiency. And also a return on investment of about $3 to $5 for every dollar invested in the private sector. So in India, for example, just giving an example of the cost effectiveness, also in India has a program that is similar to Nigeria's, and the private sector engagement for TB reduced costs by up to 25% by reducing the transportation costs and the time to access services. There was also faster diagnosis in the private sector. The Global Fund also estimates that the private sector programs, TB private sector programs in Africa reduced the unit costs of TB services by 20 to 35% with lower overheads and higher case yields. So when we talk about sustainable health financing, when we have donors and industry experts talking about sustainable health financing, also as alluded to by the previous presenters, basically they are talking about progressively moving from donor financing towards domestic funding when we talk about sustainability. And to have strong health systems and sustained health programs, including TB programs, we must be heavy on in-country investments and financing. We need to determine what interventions we want to fund. And Dr. Bioma also alluded to the National Health Strategic Plans. These plans, as we go forward and update them, must recognize the TB burden and the importance of the private health sector for disease control and, by extension, tuberculosis control. Then our national TB strategic plans must emphasize the engagement with the private sector. The states also need to develop their own health plans, recognizing the contribution of the private sector in TB control. So once we determine the interventions we need to fund, how do we fund them? There have been extensive discussions by Mr. Mayowa on the efforts being made in the country with domestic resource mobilization. And then I was very happy to hear Dr. Obioma talk about the financial sustainability plan. And as we firm up these plans, we need to ensure that we bring the private sector providers to the table. And it is so important, it's so easy to forget the informal providers that are contributing the lion's share in this engagement. There had been extensive mentions of strategies, so I'll just to emphasize what had been mentioned earlier about increasing the budget lines for TB at the national level, at the state level, and as Maya mentioned, at the local government level, particularly now that they are getting funding. So in our domestic resource mobilization effort on the TB loan project, we discovered that some states did not even have a budget line for TB, not to talk of appropriation and then release. We talked about the private sector in engagement, corporate social responsibility. It's an example of a model, the Indian model, where certain companies that achieve a certain profit margin have to contribute about 2% of that profit in corporate social responsibility activities. Some of these funds will come to the TB program, and also public-private partnership incentives like tax breaks for private providers or private contributors to health and the TB program in particular. We talked about innovative financing, social contracting. There's an example of work being done in Uzbekistan, where they have social impact fund bonds that can come get some financing for TB control. We could also look into diaspora bonds, leveraging Nigeria's huge diaspora population to contribute to the TB control as well. Of course, we've talked about the health insurance integration. We cannot overemphasize the need to do this, particularly now, to increase access and to improve the quality of services. We can look at the WHO finding that for every dollar invested in TB health insurance coverage, saved about $4.3 in out-of-pocket expenses. And then there was a pilot in Lagos State that showed a 62% drop in TB-related catastrophic costs once we had TB integrated into the state health insurance. There was also, we can also discuss the case study, what happened in Indonesia, where domestic funding was increased by about 87% simply by reallocating a portion of the tobacco tax to TB control. So now we need to take urgent steps in Nigeria. And we talked about advocacy. There's no better time than now. At all levels, we need to advocate for tuberculosis and the engagement of the private sector. We need to talk about continue the talks around policy changes. I know Dr. Bioma talked about that earlier for health insurance. Now that the states have been empowered to drive the health insurance programs, we need to be at the table looking at the policy drivers for this. Talked about private sector mobilization. Mr. Mayo had talked about what the Honorable Minister is doing, what the First Lady is doing, and we're very, very happy with this. The choice is clear. We need to act now to mobilize domestic resources or risk losing the hard-won progress in engaging the private sector for TB services. Nigeria's TB response must be by Nigerians and for Nigerians. The era of depending on donor funding is gradually fading and phasing out. Thank you.
Thank you so much, Dr. Ronke. That was really fantastic. I think these presentations, for me, it has been an emotional roller coaster because it's, I mean, the urgency, you've made the urgency very, very clear for us to see. Like, we really need to act, and it's really, really vital to act. But I think another thing that is coming through as well is the fact that there are opportunities.
Yeah.
So it's not just, I mean, the size of the problem is definitely clear to see. The fact that we need to do something about it and we need to do something about it urgently is also clear to see. But something else coming through is the fact that there are opportunities. It just requires us to put on our thinking caps, to begin to explore alternatives, begin to start to think. But this is not a new topic. We've always talked about domestic resource mobilization. We've always known that this was necessary, but maybe it was a little bit on the back burner because it wasn't as urgent. But now with the urgency, I think we are beginning to see and realize that, okay, we need to, you know, really, really stand up and start to do things. So thank you for bringing that up. So our next presenter hopefully should help us to start to think even in that way. We're going to be speaking to Dr. Anne from the Private Sector Health Alliance of Nigeria. So I'll let her describe exactly what it is that they do, but pretty much what they have a lot of experience coming up with innovative ways to finance health. And I'm sure that the TB program can learn a lot from what it is that they're doing, as well as explore opportunities for collaboration with them. So, Dr. Anne, go ahead.
Good afternoon, everyone, and good afternoon, distinguished panelists. Am I audible?
Yes, we can hear you.
Okay, so thank you very much, and it's my pleasure to be here. And every time we've had this conversation around domestic financing, domestic resource mobilization, and the role of the private sector, it just reminds me of how vulnerable we all are as a society and how important it is for Nigerians to begin to take charge of our public health and all the other facets of the social determinants of health, and seeing how we can work together to ensure a resilient society. We cannot continue to allow our health to be in the hands of the other people. We need to take charge, we need to take responsibility, and we need to ensure that we are in the driver's seat. And how do we do that? We want to ensure that we bring together all the stakeholders who are able to contribute in one way or the other to improving health outcomes, for Nigeria. When I listened to one of the other presenters, and the damage that had happened in 90 days that had taken us back 4 years, we're not just talking numbers, we're talking lives of Nigerians that have been affected because we had a stop work order. We do not know when the next stop work order will come. And the best time to begin to prepare for the next stop work order is now. And so in a little while, I'm going to take us through innovative health financing and what we do at the Alliance. I work for an organization called the Private Sector Health Alliance of Nigeria. And this afternoon, I'm happy to share insights with you in the work in which we do around domestic resource mobilization from the private sector. For looking at TB, and I know that some of these statistics are very familiar to most of the subject matter experts in this audience, we have 85% of our TB programs being funded by donors, and that's why we had the kind of impact we had when we had a stop work order for 90 days. Looking at our overall health budget, for which the TB program is a part of that health budget, we have never been able to meet the 15% Abuja declaration. Currently, as we stand with all of the investments, our health budget stands at 4.7% of our total health budget. About 60% of the TB budget is actually unfunded. And again, we still have the high out-of-pocket burden spending for Nigerians, which is why our health-seeking behavior is so poor. So one of the key ways in which we can sustain or handle our health sector sustainably will be an organized, targeted, deliberate involvement of the private sector. And I choose those words with care. The private sector is currently involved, but how organized is that involvement? How coordinated is that involvement? How targeted is that involvement? We have pockets of support across different platforms that can show better efficiency and better efficacy if we were better coordinated. Next slide, please. And so as Private Sector Health Alliance of Nigeria, what we do basically is to mobilize private sector investments to support improvement in health outcomes in Nigeria. We're supported by private sector organizations, we're supported by donors and high net worth individuals in society. Next slide. And some of the ways in which we have funded our project have been through catalytic funding. I hear Dr. Agbaje talk about catalytic funding, which would include corporate social responsibility. And we also leverage on donor presence to expand whatever investments that we have from the private sector. We also use the blended approach where we're using private sector funding, building on public sector funding to provide infrastructure support. We also support drug revolving fund establishments in healthcare facilities where you're putting in seed capital to see how robust the drug revolving fund can be and see how primary healthcare centers or other healthcare institutions can become business models that are profitable and continue to sustain upon withdrawal of either donor funds or whatever seed funding that you have put in it. We also invest in health sector through equity, and through impact funds. Next slide. These are some of the projects that we have done targeted at health system strengthening, market shaping, and scoping. We have done some that are targeted at innovation, the Health Leadership Academy, and we're also invested in research. So in whichever facet the TB program is structured, there is a role for the private sector. So the reason I put up this slide here is whichever aspect from prevention to health promotion to diagnosis to rehabilitation, there is a role for the private sector. It is how do you articulate these needs? How do you demonstrate that there is a gap that the private sector can fill? How do you speak to them in a language that they understand in such a way that translates our health information to the information that makes a business model sensible and will encourage investments? One of our biggest projects is the Adopt a Primary Healthcare Facility, where we're mobilizing funds from the private sector over a period of 10 years to ensure that we have one primary healthcare center that's world-class in every local government in Nigeria. Target for this project is 100 million for each PHC over a period of 5 years. And we have successfully mobilized funds for about 215 of these primary healthcare centers just in the second year of the project. So that means there's room within the private sector for you to work with an organization like PPM that can articulate your health needs to the private sector in such a way that the private sector is convinced that this is what they have to do, these are what the gaps are, and this is the place in which support is required. Next slide. And so what are some of the successes that the PPM model has been able to demonstrate? One of the biggest issues, and I know that the second speaker spoke to the issue of trust. The issue, trust is a major currency of trade with the private sector. You have to be able to demonstrate that the funds that have been committed will be invested as designed, will go by the design of the project, and there will be accountability for every dollar or every Nigerian naira that has been invested. We're neutral, we're apolitical, so we do not take on the affiliation of any religious organization, political party, or anything that gives a coloration to any of the projects. We're also data-driven, and that's the point where you need the intersect with the private sector is extremely important. The numbers will make the difference. We've thrown out a couple of numbers here as to how many people we lost to follow up or we were not able to provide treatment for because we had a 90-day stop order. So for us, it is how do you put this data out there in such a way that the private sector understands it and they're able to make this targeted investment. We continue to monitor the political economic analysis of the country because this is what will drive whatever investments will be made. Political statements and policies that create an enabling environment for the private sector is something that you need to understudy if you want to have sustained investments from the private sector. Again, I cannot talk enough about strong transparency and accountability framework to ensure that the investments yield or meet the needs to which they have been targeted. Next slide. And so this has not been without challenges. And so how have we overcome some of these challenges? One of the first things that we noticed is fragmentation. You have different people doing different things in silos. I'm sitting on this panel today and we're talking about investments in TB. There is investments in PHCs. There is investment in TB commodities. There is investment in all kinds of things that we know will come together for better efficiencies if we can be better coordinated. And that's one of the biggest roles for PPM. We also have the lack of trust, which I talked about. So how do we ensure that we have transparency across all platforms? We also have literacy gaps. When we talk about literacy gaps, not the financial literacy needs to speak to the health investment case. How do you present your health investment case in such a way that it makes a business case for the person who wants to invest. We have to make the numbers make sense. So we also have the challenges around bureaucracy and stakeholder engagement. So you have to carry it, the whole of society, whole of government approach. Everybody needs to be on board. I can give you an example. Recently, we donated drugs to a healthcare facility, and these drugs were not administered because some directors in some of the agencies had not been carried along. And so we needed to go back to the drawing board, to get these directors involved so that these medications, could be dispensed. So it's all hands on deck. Communication is extremely important. Going out of the door, you need to have a robust communication plan. And then what are some of the recommendations that I will make for private sector investment? We need to institutionalize public-private partnerships. We need to have, there's a strategic framework for it, but nobody is following those frameworks. How do we ensure that this framework that exists becomes a living document that people can use, that people can relate with, that people can work with in such a way that it makes sense to everybody who is looking for investment? Different people are targeting different components of the private sector. But how do we speak with one voice from a health perspective and ensure that the public-private partnerships work? What are the lessons that we have learned from previous public-private partnerships? How do we build on the things that work? How do we build on our successes? How do we ensure that we avoid the pitfalls and the things that were difficult in the last time we ventured out? How do we ensure that we have institutional memories that we can build on? How do we create investment incentives? Again, how do we make health a business case? How do we demonstrate return on investment? When we talk return on investments, we're not necessarily talking about profit for the private sector. We're talking about increase in GDP. We're talking about reduced number of days lost by workers as a result of absenteeism due to ill health. All of these are tangible things that affect the GDP of private sector organizations that translates to in-kind benefits for private sector organization. And so most times when you talk about private sector, most people are thinking they need to be making a profit, but there is different ways of demonstrating profitability in an investment that goes beyond just the bottom line. And so again, another recommendation I will have is to see how we expand on pooled funds. We do not want funds that stagnate. We want to see how we make our investments continue to work for us to provide more help for every Nigerian naira, that's being invested in health. We have to make the math, make sense to the private sector. That way we're guaranteed, continued investments. The next slide, which I think it's my last slide. So in conclusion, I would like to ask everyone that we need to move from dependency to resilience. And how do we do that? We need to prioritize domestic financing. We do not want to wait until we have a situation and then we're being reactionary. We have to be proactive. Realistically, how much do we need? How much do we have? What's the gap? How do we fund this gap? What's the role for the organized private sector? Do we have a mapping in terms of CSR? Do we have a database anywhere where we can reach out to and have people speak to the area of corporate social responsibility that they're actually interested in and that aligns with the mission and vision for which their organizations, were set up? How do we leverage private sector potentials? How do we not just keep asking for money alone, but all of the other in-kind benefits, efficiencies that are within the private sector? How do you talk to an organization in telecoms to build data portals that we can use? How do we talk to people in the oil and gas that we have environmental free societies and friendly societies? So how do we build on what already exists, not just focusing on cash as resource, but all of the other in-kind capabilities that are within the private sector? And for me, again, it's collective action if it's going to be sustained. It's an all of government, whole of society, all hands on deck approach if we're going to make any progress at all. And that will be my 2 cents worth. I thank all of you for listening, and I rest my case.
Thank you so much for that, Dr. Ann. That was extremely, what's the word now? Enlightening, and it definitely added a lot to this conversation. So I'm not going to go into that now because we're at the stage where we're actually going to discuss, and I can see that there are loads of questions. So let's just jump into that. We're already over time. And I think the reason why that is because this is such a relevant topic and there's so much to say. Because right now we didn't even allow the presenters to even fully say what they wanted to say because we're trying to push everything into the time slot. But I'm also encouraged by the fact that we still have most participants still joining, still wanting to ask questions, dropping questions, which means or tells me that there's a consensus that this is important enough that even though we're taking a longer time than we initially intended to, it's still worth it. So I'm just going to first start by opening it up for questions. Um, Please raise your hands if you have any question to ask. We'll first jump into the questions that have already been put up, and then we can now start to, to share. Also, for every presenter who has spoken before, particularly Dr. Obioma, I'm sorry that we cut you short. If you had any other insights that you feel were important that you were not able to speak of during your presentation, please go ahead to use this forum to do so. I don't know if Dr. Ogiri is still with us. Dr. Ogiri, you have quite a few questions. Do you want to come and speak on them? And as in, you want to come up and talk about some of the questions that you have? Or if otherwise, I can read them out since it's written.
Okay, so can I go ahead?
Yes, please.
Okay, yeah. So congratulations to all the presenters. I think the issues are quite insightful. I was just trying to find out from Dr. Bioma. Yeah, quite a lot is being said on out-of-pocket expenses, particularly in the private sector, also in the public. But then, we need to be a bit specific in addressing the gaps. So I was asking about the main drivers of these out-of-pocket expenses. And then for Sheshi, your research or that little work you did on how you mobilize states, I think that was quite insightful, but I just wanted to know your experience on the ease of release of funds. And indeed was available for PPM programming. Dr. Agbaji, I think those things are there. People can simply just read. I don't want to dominate this. Thank you.
Okay.
The return on investment, I wonder how much of it, if there's a mechanism from the research on how we plow back the return on investment into PPM. And then the Ant's presentation, quite insightful. In the integration, how do we ensure effective human resourcing for TB within the context of integration? Thank you, Anova.
Thank you, Dr. Sheshi. Dr. Obiama, do you want to go ahead and answer his question? Or anyone? I'm seeing questions for Dr. Sheshi as well, Mr. Mayowa. In fact, every presenter has a question from Dr. Ogiri. So anyone can just go ahead and respond, please.
Okay, all right.
Okay.
Thank you, Azi. I think the question Dr. Giri is asking, or directed to me by my guy, the top, is how are we ensuring efficiency in utilizing the funds being donated from the private partners?
Mr. Mayo, we seem to have lost you. Another question that I have that is related to that, if you can still hear, and you can write that down if you're not able to, if your internet isn't responsive. I wanted to know, so for the $700 billion, sorry, naira that has been donated by the government of Nigeria, how is that split across the three different disease programs, TB, HIV, and malaria? What is the determinant for how it is being distributed, and do we know how much of it is actually coming to TB? So feel free to write that down. So as we wait for other people to respond and also to ask additional questions, I think one thing that maybe one question that I have for Dr. Ann is that how can we collaborate better with Pishan? We've had this discussion before, and Pishan is not really in the radar, or rather, TB is not really within the scope of what Pishan is doing specifically. But there's a lot of work happening within the TB space as well, as far as private sector is concerned, both engaging providers as well as trying to um, uh, mobilize resources. So is there any way to formalize that and have maybe more concrete ways to collaborate beyond this going forward, especially given the work that we've already started to do in this space?
Okay, thanks, Azi. I think it will be helpful to have a conversation after this, and then we'll see what the level of private sector engagement that you're looking to do will be. Are you looking to engage private sector providers, or you're looking to looking for private sector who can support with domestic resource mobilization? So on what side of the divide is it? Is it the demand or is it the supply side? And then we can look at what actively works.
Okay. The short answer is both, but then yes, I think we can have conversations beyond that. Thank you.
Okay, Azi, is it okay if I can
Yeah,
talk
please
now?
go ahead. Yeah.
Okay, thank you. Let me start with your last question to Dr. Han. Stop TB Partnership has made efforts to work with patients several times, and there have been challenges, and also it has been one of where we have been successful. It has been one of, and so how we will, as an organization, would like to see the possibility of having a more engaged relationship with patients. I mean, there are comparative advantages on both sides, and if we can leverage on each other's strengths and vast networks, I think we'll be able to achieve more for tuberculosis. So, uh, if it's okay by you, I'll be reaching out, and then we can then see how to take it forward from there. On the question from Dr. Giri, I was explaining that the funds we receive from private partners are being utilized with discussion with the National TB Program and the Office of the Minister. Because he is taking the lead on this, he's very much interested. We give you a report of every penny and copper that comes in. And so we sit down with the National TB Program to discuss what is the priority in terms of what needs to be procured or what needs to be done, and then the funds are channeled directly to that. It's a very open process, and so that makes it very efficient. Thank you.
All right, thank you, Dr.
Okay.
Maiwa. So any other comments from any of the presenters?
Okay, let me go, Aji. I think I have two questions. One from Dr. Ogiri, how easy the release of funds were and what's available for private sector work. So based on what we found out at that time, of course, we had to go through some learning processes, and we worked pretty closely with Stop TV Partnership. As Mr. Mayo will always say, we have to learn the language of the politicians to be able to get these funds out of them. And so we did that. And honestly, we found out that the release of funds was easier, especially if you know how to go about it, even a lot easier than the allocation. So if you're able to put things in place, know the necessary people to meet, know the language to speak, and of course, put out things that will bring relevance to those government employees, we're able to get these funds released once they have been appropriated. Now, we were not prescriptive as at that time, because of course it's a journey. We even wanted to show that, yes, we could get money domestically. So we're not prescriptive on how these monies will be spent. So we will usually just give all the options available to the key players. Oh, these are some of the gaps that we had noted, and these are what, if you have these funds, you could do, and we allow them to take those decisions on what the money is spent for. So we didn't really track specifically how much went for private sector engagement. Of course, as I said, it's a journey. Of course, subsequently, we may begin to track all of that. And that will take me to the second question that was asked. How we're able to do what we did. As I said, it's just engaging with the right stakeholders in the corridors of power. Of course, when we went in, we did our baseline assessment, saw what had happened over the past 5 years, and in most of the states, money had been allocated, but they were not released for TB services. So we did all of those baseline assessments. We were able to also clearly states the gaps in TB implementation in these states, and then we're able to show these facts to the relevant people in power and showed them the extent of donor funding and what those other funds that has been appropriated from the state will be able to do if that money was released. And we also gave them the leeway to understand that this money will still be used by their own key players to implement TB services in the states, and of course, it will be of benefit to the people. Of course, you also do a little bit of paparazzi when some of these funds are released so that it also boosts their ego and even helps them to release more. So these were some of the things we did, and as I said, it was an ongoing process at that time, and we're able to get funds released. Thank you.
Thank you very much, Dr. Sheshi. So the floor is still open. Presenters, participants.
I'd just like to
Yeah.
add on to what Dr. Sheshi alluded to.
Okay, please go ahead.
The experience with the funds release. What we discovered our domestic resource mobilization effort, particularly concerning getting the state governments to the budget line for tuberculosis, to increase funding for states that have budget lines, is the issue of capacity and collaboration. There needs to be a more systematic process for getting funding for tuberculosis at the state level. I say this because my experience was that there were varying levels of capacity amongst the state TB staff to approach the politicians or to even approach the Ministry of Finance to get these funds released. And with the turnover of the program managers, at times this capacity is built over time could get lost along the way. So something more systematic, something as simple as knowing who in the Ministry of Finance to pass the memo to, the follow-up processes. And then that collaboration also between the Ministry of Health and the Ministry of Finance is really, really important. Establishing a mechanism for that strong collaboration cannot be overemphasized. So mapping the power brokers, the stakeholders within the government is as important as mapping them private. Thank you.
Thank you very much, Dr. Ronke. So any other speakers? Any other questions? Any other comments? Okay. So let me share my thoughts. Should I say a summary of everything that we have discussed and all the things that I have learned? So I found it extremely useful. This webinar has been extremely useful. It has been extremely educative. As I said, it was an emotional roller coaster because there was a lot. It's kind of overwhelming when you start thinking about all the funding that has been lost and potentials, and you don't know what the future looks like. And basically, the bottom line of some of those graphs we see is that people are dying, and there's potential for more people to die, and we're just basically watching the funds that we had to do it go away without any real solutions. But I think what this webinar has shown is that these solutions do exist, that there actually are opportunities, that when we are talking about sustainability, our donor funding has never been sustainable. And we should count ourselves lucky that we've had it so far and that we continue to have it. But we should start to think beyond that. There has to be a shift in our mindset in terms of how we want to fund our programs. And I'm glad to hear from all the different presentations that there is hope, that there are opportunities, that there are resources domestically that can be mobilized, that there are people who are already doing this work, that there's baseline assessments that have been conducted by different organizations, that we have the data, we know what to do, right? It's just that we have not necessarily been doing it, and we've not been doing it very strategically. We've not been doing it in a very collaborative way, and we've not necessarily been mapping or tracking what is actually going on. So I think this is a call for all of us as a program and as Nigerians to take this more seriously, to see this as a wake-up call, and to sort of start to build on what we already have. We're not starting from nowhere. We have resources that we can actually begin to leverage and start to do more work. So I just want to thank every presenter that has spoken today. Each presentation was fantastic. And so we ended up having 5 fantastic presentations. Thank you for the participants. Thank you for staying to, even though we have overshot by almost 30 minutes and people are still here and still engaging. Thank you so much for that. Thank you for the work that you all do, because it's extremely important. Thank you, Pishan, for joining this platform. Thank you for everything that you have shared. It's definitely insightful. I'm glad to hear that connections are already being made, and that this hopefully will lead to, collaborations in the future that will be helpful to Nigerians as a whole. I will just pass this over to Stella to end for us. But in a nutshell, I just want to say a big thank you. I can see Bolanle, your hands are up. Do you want to say something? Please unmute.
Yes, Aji, thank you. Yeah, thank you. I want to echo your appreciation to all the presenters for very insightful and informative presentations. Dr. Obioma in our opening slides talked about the sources of earth financing in Nigeria. And of course, top on the list is out of pocket, and then we have government spending, and then she mentioned earth insurance. And almost every presenter actually mentioned or made reference to earth insurance, that is integration of TB services into earth insurance schemes. And I want to cone in on that. But if you ask me, that is one specific way to bridge the gap between the public and the private sectors to mobilize resources, and it's always a win-win for both the clients or the beneficiaries who are covered and the facilities providing services to them.
And so I'll speak from the experience from my own program, that's the USAID Local System Sustainability Program, where initially our mandate was one part of it under the heart office in USAID was to integrate TB and HIV services into health insurance schemes. But somehow along the line, TB got dropped off, right? And this was attributed to lack of funding or TB specific funding from the heart office. For the first year, we kept putting TB HIV in every work plan, and then we're asked to amend that and focus on HIV. And as we speak, we have over 10,000 PLHIVs enrolled on health insurance in Lagos, Kano, and Akwa Ibom. And more recently, the Global Fund grant started, and TB is included. And I know, as a matter of fact, that in states like Lagos, Gombe, and Kwara, there's already preliminary work to integrate HIV, TB, and I think malaria into health insurance schemes. Focusing on TB, the issue we have in our country is that we have many successful projects or pilots ongoing in different parts of our country. But the challenge we always have is scope and scale. And so we have LHSS doing HIV in 3 states, and that's HIV integration into health insurance. And then we have Global Fund doing pilots in some of these states. Does our country have the will to scale this up to all parts of the country? So I don't just have successes in some parts. And then speaking to scope, how robust is the benefit package? As someone coming from the TB program, I was really pained when we couldn't implement TB integration under LHSS, but I'm also specific about the benefit package. We know that our TB patients have non-TB specific health challenges. And somebody who also worked on MDR-TB, I know how difficult it is to manage adverse drug reactions with very little resources and other challenges that the patient can have. What stops a TB patient from having acute appendicitis, for example, or having ophthalmic issues that requires surgical interventions? But if they are enrolled on health insurance, and if the benefit package is robust enough, they will be covered. So my challenge to the NTB-LCP, I know we are involved in the Global Fund grant, is to look at the benefit package. What does it include? Does it include the adverse drug reactions that TB patients suffer from? I think it's commendable that in the pilot state of Gombe, Lagos, and Kwara, and some other states, I think, we have MDR TB patients also being covered. And I was really very happy about that as a Nigerian and somebody that had worked on the TB program. But let's look at the benefit package, how robust it is. The only challenge I see with the Global Fund grants, and I will express it very clearly, is the fact that the donors are still the ones paying the premium. Under USAID LHSS, we used our country's resources, that is BACPF. I see Stephen posted some information on BACPF on the chat, and I'm really happy about that. The government of Nigeria paid for these 10,000 PLHIVs that were enrolled on health insurance under LHSS, but they used Basic Healthcare Provision Fund from the federal government and the state health equity funds. Lagos actually enrolled more PLHIV using the state resources, that is equity fund from the state, than even BACPF. That's like Kano also doing the same, and even Akwa Ibom. And so we need to look at domestic resource mobilization independent of donor funding. What we just did as partners was to create the learning, the capacity building, the skills for integration, but you require skills to do it. That was what we did, and the trainees, but the government paid the premium. And so when the stop work order came, I was sleeping very comfortably in my house because I knew their premiums are being paid by the government of Nigeria. And unless something happens to our consolidated revenue fund, BACPF will continue, because it's a first line charge, and the state equity funds are also first line charge. So my call to Nigeria is to look beyond donors paying the premium. There are different levels to health insurance integration for HIV and TB. This first level is general services. The second level is TB and HIV specific services. The third level is when you get to the point of even paying for your own drugs. Dr. Ronke mentioned Indonesia. We have countries like Vietnam where they buy their HIV and TB medicines using health insurance funds. That is the last level. That's the peak, the pinnacle of that TB HIV integration. And that is what we should be aiming for. We should have a roadmap for achieving this. And one last call to the TB program. I shared something with Dr. Obioma recently about, we all know about the sector-wide approach. I mean, that is the resource mobilization at its best. This is the government of Nigeria putting all resources in one pot. And guess what? When they were developing the indicators to monitor and track achievement, 42 of them for the swap intervention, they call them the 42 core indicators. Under communicable diseases, they included indicators for HIV, They included indicators for malaria, and there was no TB indicator. It's something I still plan to discuss with the SOP office, stop work order or no stop work order. And I think it's something that Obioma has also, committed to taking up. And so we need to be out there. We are doing a lot in the TB program. Our successes speak for themselves, but we need to be in national discussions, national dialogues on how to make TB be on the front burner and not lag behind HIV and malaria. And that, to me, is a call to action. Along with everything everybody else has said, those steps that we are outlined, let us include getting in the forefront of national dialogues, discussions, and the health sector reforms that Nigeria is currently implementing. That's my contribution. Thank you.
Thank you, Dr. Bolanle. I actually raised my hand before you, but thankfully, as you didn't see it, because it was good that you talked before I respond. So I'll start with the indicator, core indicator in the SWAP. It's been handled. We've had a discussion on it, and one indicator on TB program would be included under the communicable disease as soon as possible. So we've done the frame for that indicator, and they are out of the country now. So once they come back, it's one of the things we're going to take up, finalize. So we didn't drop it on the line. Thank you for bringing it. Oh, yeah, we followed it through. And just to mention that the TB program, we've actually gone some steps in terms of financing, sustainable financing. The thing is that when you're laying the foundation, it's not very visible because there's a whole lot to do in terms of laying the foundation. So I like the comments you have made in the revised guideline. TB already has been incorporated in that guideline. It took us a lot to get to the point because first is for us to be part of it. And even though it's DSTB treatment, diagnosis and treatment, it's one step for us because we know we need to get into this fund for us to be able to even advance further into the health insurance and all we need to do with the packages in the health insurance. So because we need to ensure that the monitoring framework for the basic healthcare provision fund, we also have TB included in it. That is what we are pushing now. So now we are in the guideline. We need to be in the monitoring framework so that when the monitoring is going on, we are also being monitored. Because if we are not measured within the monitor, you can have your name in it and nothing really is happening with your program. So that's one aspect we are dealing with now, and I'm sure shortly we're going to have that resolved. Secondly, we also, as a program, we don't have a budget code. So most of our things in financing is modeled up. And because it's modeled up, nothing really comes to us with our own budget code. That is another thing we are looking into also to ensure that we have a spelled out for TB financing in the budget so that whenever the government is doing every other conversation that have to do with multi-year planning, we will know that somehow we'll be part of it, will be a lot visible than what we have now as a program. Then thirdly, we've defined our financial sustainability index. We have, which is very comprehensive. And believe you, TB program, we know all the gaps we have in terms of financing. Some are from us within the TB program, some are outside, even with the non-health sector. So we are very conversant with it. And everything we are planning, the building block of what we are planning is to work on that such that we can come to the optimum sustainability. Because the insurance you mentioned with the Global Fund, it's more like a pilot, giving view. But that giving view is to see what, we had an actuarial analysis, which was not even utilized by states. So now we are trying to bring it in form of like incentivizing or kind of pushing states to take up this. Once they're able to take up this, what we are working towards, as they are practicalizing this through the service packages, we are coming from basic healthcare provision fund to be able to even enter into this more health insurance package that would help us ensure that government pays for this premium. So we are not quiet with what is happening. Whatever is happening with the Global Fund is more like appetizer, trying to find a model. Okay, how is it going to work in the state? What do we need to pay for? And what exactly do we need to do before we finally come through this other side of the program? So we've also done investment case. We have an investment case now done for TB program, and we've been able to define our return on investment, both mortality, saving, life, morbidity. We have it all stipulated. So with that, it's more like we're having proof of what this funding is doing. If you invest $1, this is what you get on return on investment. So it's more like we're doing a lot now, but because we are on the foundation level, it's really not yet very apparent. But we hear you, we understand what you're saying, and I'm really touched by the passion you have, because I know every insurance discussion, I just hear you talking about TB, which is amazing. And that's one of the things we may not have a lot of us in different platforms, but the places where we have people from TB, you will see the passion. No matter what they are pushing, they push for TB. So we will still all join hands together, move forward in this, and do what we need to do for the program. It's not just about the national program, it's all of us together, wherever we are. So if there's something, if you hear something, say something. If you see something, say something. Get us involved, inform us ahead of time, and our work, whatever we need to do in terms of bureaucracy or from the government, we will do from our own part to ensure that we lead the TB program to a sustainable point. Thank you very much.
Thank you, Dr. Obioma. Thank you very, very much. Am I missing any other hands? I don't see any other hands up, right? So, Stella, do you want to?
Yes, yeah. So sorry, we did not intend to keep us too long, but you can agree with me that it's worth the while. So just summary of a few takeaways. So we know that health financing should be given optimum attention. It's very clear for us now. Then some private sectors we've heard have made wonderful donations to TB control. Then we know that USAID fund freeze order is affecting our case finding now. And we need to leverage, if possible, diaspora funds. And there is need to bring all the stakeholders together. Organized, targeted, deliberate engagement with private sector is very important. So next step, few possible next steps, we need to have a template that is encompassing to enable us capture the funds we get from the private sector so that we don't underreport funds from that sector. And we must ensure that TB services are integrated into the health insurance system. And according to Dr. Ronke, the choice is clear. We must act now to mobilize private sector funds for sustainability of TB financing. So we want to thank everyone, especially our panelists that have shared so much with us. We want to thank Petra and Aji who have put this together. We also want to appreciate our acting national coordinator who is still hanging on to this call. So I don't know whether he's around, he's still there to close this session for us. Dr. Clement. Dr. Clement. Okay, so I think, Aji, that is all from my side. Thank you very much.
All right. Thanks, everyone. Thanks for hanging with us right up till the very, very end, despite the fact that we overshot the time. The presentations as well as the recording of this. First of all, this is live streaming on YouTube, so you can already have access to that immediately after this is over. But then the recording and the presentation will be shared. We're going to put it on our website, and then we'll share a link over the next couple of days. Thank you so much, and please reach out if you have any additional questions or if you have any other topics you think that as a group we should be discussing. And please let's continue to have these conversations because they're extremely important. Thank you so much and enjoy the rest of your day. Bye, everyone.
Thank you.
To everyone.
Bye.
Thank you, Azi, Dr. Stella. Thank you.